Shoulder and Elbow Fellowship Program in NAEON. I am a lieutenant of the Brazilian Army. I will start talking about epidemiology. The incidence of open fracture is 30.7 per 100,000 people per year. In a demographic, its average age is 45 years old. A definition, also called a compound fracture, breaking the skin under underlying soft tissues, leading directly into or communication with the fracture and its hematoma. Most often, this wound is caused by fragment bone breaking from the skin at the moment of injury. And the pathophysiology most common is high energy trauma or punctate fracture that transfix the skin and reach the external environment. This can be caused by an automobile accident or even a shot by firearm. Initial evaluation, the most important thing is save the life of the patient. So we start with the ATLS. Upper extremity should be examined for really apparent soft tissue injury, and osseous and deformities of the joints should be due after. So the first priority is save the life of the patient. And we have associated conditions, compartmental syndromes. The presence of open does not preclude the occurrence of a compartmental syndrome in the injured limb. So mainly in the elbow, we have multiple possibilities of compartments. So we have to take care about this kind of things. And the soft tissues, neurovascular injuries. So we have three big nerves in the elbow, and they can be easily affected by the trauma. In the image, we can have radiographs. We can include the joint above and beyond the fracture. And TC to watch the periarticular injuries. It can provide more detailed information regarding the fracture and the personality of the fracture. It could be easy to plan, to think about the surgery, what we're gonna do, what we can do with the bones and the things around there. And if we think about vascular injury, we can use a Doppler or arthrography, but also we have to call the vascular surgery to help us in this case. And we have a Gustilo-Anderson classification, and why we use this, it's helped to guide our treatment, decisions and strategies, and depends on the severity of the soft tissues injuries, the experience of the surgeon, how implants we have, the availability, and the conditions of the patients. The treating physician may choose in between to define the fixation as compared to delay fixation and external fixation. And we have to recommend antibiotics, depends to the type of Gustilo. So we have 1 and 2 classifications of Gustilo. We have just cephalosporin, and the 3 we have to use together aminoglycosides, and we have to put penicillin if you have a farmyard contamination. And why we use this? Because we can have an idea of a prediction of our patients if you have an infection, fracture healings, and even amputates. So I'm gonna show a case that appears in a public hospital here in Brazil. A patient had 33 years old, victim of a firearm shot, inability to mobilize the elbow, forearm, and right hand, total loss of sensation in the limb, and dynamically stable. This is the paper radiograph, the wonderful radiograph that we have. So we can see a total destroyed of the distal humerus, and we don't have a lot of things to do with this patient. we don't have a lot of resource, and it's the picture about the lesion, and I'll try to put a video. It's to show the lesion of the brachialis artery. So in conjoint with the vascular surgery, we decide that the limb was not available. We do a primary amputation. And why it requires different treatments? An open fracture requires, a different treatment than the closed fractures, because once the skin is broken, the bacteria from the dirt and other contaminants can enter in the wounds and cause infection. For this reason, early treatment for an open fracture focus is preventing the infection at the site of injury. In the absence of a life-threatening injuries, there is no clinical advantage to perform the surgery within 6 hours of the injury versus 24 hours. The contamination with dirt and debris and the desvitalization of the soft tissues increase the risk on infection and other complications. Non-operative treatments, you have to use urgent intravenous antibiotics and do a tetanus prophylaxis. And this is the most important thing to do, and irrigation, debridement, and extremity stabilization and dressing. In the operative treatment, the time is very important. That is conflict, but the most center perform irrigation within 6 hours, but it's not a rule. We do it because people do it all over the world. So we do it's the same way. In serial debridements and irrigation, perform every 24 and 48 hours as needed. The second loop, the third loop, whatever we need, we have to do the irrigation and debridements all as we need. An operative treatment, the use of external fixation is acute settings, provides early stabilization and allow for the treatment of neurovascular or soft tissues injuries prior to defining reconstruction. In rare stents, external fixation can be used for definitive stabilization. Many times in Brazil, we use the external fixation with the definition to define definitive stabilization, because we don't have how to treat this patient better. It's a little strange reality, but for us, it's not so, it's very common. And we have the safe zones to put the shunt pins, and probably everybody know about it. And open reduction, internal fixation. In open reduction, we have to think about how we're gonna put the scientists. We have in the distal humors, two possibilities, the orthogonal and parallel plates, and we have a conflict how this one is better. But Dr. O'Driscoll in the last paper said that the parallel plates are best and more stable than the orthogonal, but sometimes we have to think in the fracture. Sometimes the orthogonal plate's gonna be more, how can I say, gonna fix it better than the parallel. So each fracture is different, and we have to make a decision on time the surgery, if you have orthogonal or parallel plates. Olecranon, the most common plates, it's a plate is more common for multifragmentary. That's the bigger part of the fracture is multifragmentary, so it's the first choice, because if you have just put pins, it could be not so good like a plate. And the radius fracture, we can choose arthroplasty, because sometimes not possible to fix it with the plate and screws. So arthropods is a very good option to restore the movement and the conformation of the joint. So now I bring this paper. It's a Spanish paper from Dr. Prado Lopez, and he chose a very interesting way to reconstruction the distal humerus. It's a pipe patient, when 26 years old, male. He had a car accident, and simple radiograph study of the left elbow reports a final diagnosis of grade 3B open fracture of the left humeral. And we can show the X-ray. Intravenous antibiotic treatment, proceed to clean and debride the elbow, wound and temporarily stabilize the fracture through external fixation. And this is the different thing that he did. He take off the radial head and puts by inside of the hemitrochlear to compound the distal humerus. So he saw that the medial ligament was okay, and if it's okay, you can take out the radial head and rebuild the trochlear. So we can see here, this is the radial head in the distal humerus, and he fixed it with plates and put more bones to do a contact with the other parts of the distal humerus. So he rebuilds the hemitrochlear with the radial head, and it's gonna show that it was very, very, very functional. 2 months ago, he preferred the rehabilitation service to improve the elbow joints balance. It's a functional elbow, have not a total extended, but total flexible, but was good by the bad fracture that he has. And soft tissues coverage, early soft tissues coverage or wounds closure, it's ideal. Increased risk of infection beyond 7 days. And I will bring for you some options. Negative pressure wound care and skin graft. So you can see that have a big loss of skin, and we use a negative pressure and a skin graft. Another option is flaps reconstruction. This is not so far. It's a local flaps reconstructions to the arm to the elbow. And muscle flaps. This is the brachioradialism muscle flaps. And this kind of flap, it's significant. This better because he can cover parts that have a tension. It's good for the elbow because he can receive the tension without break. So it's a very good option for the elbow. Complications, we have a surgical site infections, fracture-related infection ranges less than 1% in grade 1, and open fracture, it's more than 30% in grade 3. Osteomyelitis is a very, very common thing to treat in the complications. And now I'm gonna show you another case. Male, 15 years old, car accident with trauma in left elbow, no neurovascular lesion, hemodynamically stable, and this image, a C3 fracture with a Agostino 2. This is the CT scan that we can see have a big break, but we can, in this case, 15 years old, we tried to fix it. We do irrigation, debridement, extremity stabilization, and primary suture of the skin lesion. This is the external fixation and the suture of the skin lesion. And for day after, we do the final fixation with parallel plates and reconstruction of the articulation, the joint, with very good results. And to final considerations, save patients' life, antibiotics, irrigation, and debridement as soon as possible, and a good multidisciplinary team, infectiologist, vascular surgeon, plastic surgeon, the best fixation to restore the articulation, and do your best with what you have in your hands. Thank you very much.
Thank you so much, Dr. Barcelos, for this very interesting and illustrative talk. It was an honor to join us tonight, sir. Thank you so much.
Pleasure.
Dr. Ahmed Sheikh from UK is the moderator with Dr. Barcelos. Dr. Ahmed? Dr. Ahmed? Okay, we are ready to receive any questions to Dr. Barcelos. We have a question. When do you do primary fusion, if any?
The primary fusion, it's our option. We try to not use this resource always, but sometimes if patients we have who will need strong and will need the vein to work and something like this, it's a good option, but it's not my preferred way to treat. I prefer to try to restore the articulation, even it's not work. I don't have a lot of experience of this way.
Another question from me, sir. What's when do you can say that this is a non-reconstructable condition of elbow fracture?
Sorry, it's cut.
Have you faced a case that you said this is not amenable for reconstruction? What's the degree of comminution that you can say with it, this is not amenable for reconstruction? I see some cases, very comminuted cases, and you did it excellently. Is there a case that you can say that this case is not amenable for reconstruction?
I'm back.
Dr. Barcelos? Dr. Barcelos, you are with us? I think we lost Dr. Barcelos. Now we will go